Hi, good evening, everyone. Welcome you to this another, interesting webinar from the Indian Chest Society. And this seminar, today's webinar is on a very interesting topic. And this is going to be interstitial lung disease, tips and tricks. We've been having this series of webinars from ICS, courtesy Samaria sir, Rajadhar sir, and Amitanin ma'am. We've been doing a stellar job of organizing these webinars. And the series on interstitial lung diseases has been a super hit. And today's is kind of, the icing on top, because today we are going to actually sum it up. And the panel discussion today is going to be the tips and tricks on interstitial lung disease. We are going to discuss very contemporary topics, very important, clinically relevant topics. And I have a stellar panel with me today, the best of the best from the country, and I'm really looking forward to it. But before we take you to the panel discussion on the management of interstitial lung diseases, let me first introduce you to today's speaker, because before we start with the panel discussion, we need to sum up, what is there in the management of interstitial lung disease. And I think Kaushik is one of the best people to do that. Kaushik is a professor in pulmonary medicine at Sri Ramachandra Medical College and Research Institute, Porur, Chennai. He has been awarded with the Young Scientist Award NCCP 2013 and has multiple, awards and feathers to his cap. Dear friend and someone we look forward to speaking every time he is there. And Kaushik, you have another 20-25 minutes with you to sum up the tricks and tips that you have for us for interstitial lung disease, and then we will take the panel discussion. So over to you, Dr. Kaushik. Kaushik, you need to unmute yourself. Please unmute. Yeah.
Yeah, thank you, Dr. Arjun, for the kind introduction. So, I think today I have been asked to talk about approach to interstitial lung diseases. It's a very huge topic to cover in 20-25 minutes, but I will try to do justice to give actually the glimpse of how to approach an interstitial lung disease at bird's view. So what is interstitium? Interstitium is a collection of supportive tissue within the lung that includes the alveolar epithelium, pulmonary capillary endothelium, basement membrane, the perivascular and perilymphatic tissues. So what you see in between the alveolus and the capillary basement membrane here is the interstitium. So what is an interstitial lung disease? The term interstitial lung disease comprises a diverse group of diseases that leads to inflammation and fibrosis of the alveoli, the distal airways, and the septal interstitium of the lungs. So what is diffuse parenchymal lung disease? Many of the conditions that have been traditionally included under the heading of ILDs are actually associated with extensive alteration of the alveolar and airway architecture. For this reason, the terms diffuse infiltrative lung disease or diffuse parenchymal lung disease are preferable over ILD in certain conditions. Different types of ILD have distinct pathophysiology, clinical manifestation, and prognosis. All forms of ILD can cause irreversible pulmonary fibrosis. Pulmonary fibrosis may progress even when the underlying cause of ILD has been treated or removed. Approximately 30 to 40% of people with ILD develop a progressive pulmonary fibrosis. PPF causes respiratory failure and is associated with a median survival of approximately 2.5 to 3.5 years. Coming to the etiology of diffuse interstitial fibrosis is still unknown. Several theories have been put forth. None have been actually proven. The theory which has received widest acceptance is that of hypersensitivity, and immune reaction. Some patients have an increase in serum gamma globulins, the fraction known to contain the majority of circulating autoantibodies. The occasional familial pattern suggests an allergic diathesis as well. Coming to the pathophysiology, IPF develops due to an abnormal wound healing response in the genetically susceptible individuals following repeated alveolar epithelial injury. Approximately 2 to 5% of individuals with fibrotic ILD have other family members with ILD. Hypersensitivity pneumonitis is characteristic by immune-mediated granulomatous response to the inhaled antigen. In scleroderma and idiopathic inflammatory myopathy, specific autoantibodies are associated with the development of ILD. In rheumatoid arthritis, the genetic profile of the individuals who develop ILD is similar to that of IPF. Coming to the Indian scenario, the idiopathic pulmonary fibrosis or hypersensitivity pneumonitis actually is responsible for 43 to 46% of ILDs in India. The sarcoidosis contributes to 22%. ILD secondary to collagen vascular disease contributes to 18%. Extrinsic allergic alveolitis corresponds to 6%, and others corresponds to 11%, contributes to 11%. So coming to the classification, we classify ILDs into idiopathic, autoimmune related, exposure related, ILDs with cyst or airspace filling, sarcoidosis, and others. Coming to the idiopathic, we have idiopathic pulmonary fibrosis and non-specific interstitial pneumonia, acute interstitial pneumonia, cryptogenic organizing pneumonia, desquamative interstitial pneumonia, pleuroparenchymal fibroelastosis, and unclassifiable interstitial lung diseases. And autoimmune, again, the whole set of connective tissue disorders. And exposure related, we have hypersensitivity pneumonitis, pneumoconiosis, RBILD, drug-induced lung injury, radiation-induced lung injury, and post-infectious interstitial lung disease. Coming to the components of ILD evaluation, we have patient evaluation, detailed history taking, clinical examination, involvement of multidisciplinary team assessment, establishing the diagnosis of ILD, functional assessment, identifying complications, therapeutic management, supportive care, and finally, lung transplant in some patients. The step one towards the approach of ILD is a detailed history where you have to discuss in detail about the symptoms, history of exposure, coexisting systemic symptoms, and family history. Symptoms such as dyspnea is a primary symptom of ILD. Gradual deterioration in exercise capacity can also be there. Resting hypoxemia and resting dyspnea in advanced stage of ILD can be there. 30 to 50% of patients with IPF report with cough that impairs with quality of life. Fatigue and weight loss can be a symptom during presentation. Unintended weight loss in patients with ILD is associated with poor prognosis. A greater than 5% decrease in weight at any time over the course of the disease is associated with 2.5-fold increase in risk of mortality. Coming to the detailed history on exposures, includes smoking, occupation, environmental, medications, radiations, and minor hobbies associated with the patient. Detailed history of systemic symptoms include joint pains, rashes, skin involvement, Zika symptoms, muscle weakness, swallowing problems, and abdominal symptoms. Coming to the clues from the initial evaluation that suggest specific type of ILD, the rapid onset and worsening history actually suggests acute interstitial pneumonia, viral infection, and acute hypersensitivity pneumonitis or acute eosinophilic pneumonitis, drug reaction, or organizing pneumonia, or an CTD like acute lupus pneumonitis or diffuse alveolar hemorrhage. History of smoking is related with RBILD, DIP, and PLCH. Occupation like pipe fitter, foundry worker, or coal miner is frequently associated with pneumoconiosis. Pneumotoxic drug exposure is related to drug-induced ILD. If patients complains of hemoptysis, it can also be associated with diffuse alveolar hemorrhage, pulmonary capillaritis, pulmonary veno-occlusive diseases, and LAMP, and superimposed complications like pulmonary embolism or neoplasm. If a patient also complains of pleurisy, it can be because of connective tissue disorders, especially like SLE and rheumatoid arthritis. If patient complains of wheezing, that can be HP and EP. You should suspect of HP and EP. If patient complains of eye symptoms, then you should suspect CTD, sarcoidosis, and polyangiitis PGA, and impaired vision combined with albinism and Puerto Rican heritage, you should suspect HPS, and rashes, you should suspect sarcoidosis or CTD. So all these symptoms here is related to CTD like rash, abdominal reflex, dysphagia, Zika symptoms, Raynaud's phenomenon, arthralgia, arthritis, muscle weakness, morning stiffness, and age more than 70 years, you should think of IPF rather than other ILDs if the HRCT is suspicious for IIPs. Coming to the step 2, which is the clinical finding, patients usually have exertional desaturation. Clubbing is seen around 7 to 42% of patients. Velcro crackles at lung bases are seen in 93% of IPF patients and 73% of non-IPF patients. End inspiratory squawks is seen in hypersensitivity pneumonitis. A loud P2 and pedal edema can also be seen in advanced stages with concurrent cardiac involvement. Step 3 is imaging, where we go ahead with chest X-ray first. Chest X-ray can show bilateral reticular shadows in the lower zone, suggestive of interstitial involvement, which is shown here in red circles. Compared with CT scan, the sensitivity of chest radiography for ILD is 63%, but sensitivity is quite good, which is 93%. Coming to the next step, which is the very vital and important step in the approach to ILD and diagnosis of interstitial lung disease, which is a ℏ-CT thorax. The CT thorax is the primary diagnostic test for identifying and diagnosing ILD with approximately 91% of sensitivity and 71% of specificity for subtypes of ILD. A spaced ℏ-CT approach can be done in which thin sections 0.5 to 1.5 millimeter thickness scans are obtained at 10 to 20 millimeter intervals, or volumetric ℏ-CT can also be done without any intervals and the entire volume is captured, but the risk of radiation here can be high. The basic patterns of ℏ-CT includes the usual interstitial pneumonia, the non-specific interstitial pneumonia, the organizing pneumonia, the diffuse alveolar damage, and hypersensitivity pneumonitis. So this is the very important step in your approach to ILD, where you have to categorize your ℏ-CT findings either in one of these 5 categories. If it is a usual interstitial pneumonia, it is usually represented by subpleural basal reticulation and honeycombing with associated traction bronchiectasis. If it is a non-specific interstitial pneumonia, it is predominantly basal ground glass attenuation with fine reticulation and traction bronchiectasis, and subpleural sparring is present. If it is an organizing pneumonia, there is a patchy consolidation. Cryptogenic disease is often unifocal, while autoimmune tends to be multifocal. An atoll sign, which is a central ground glass opacity with surrounding ring of consolidation, is seen in the organizing pneumonia patients. A diffuse alveolar damage, which actually presents with the exudative phase showing widespread patchy dependent ground glass opacities. The organizing phase shows widespread consolidation and a dependent distribution with traction bronchiectasis and often cystic destruction of the lung. The final one is the hypersensitivity pneumonitis pattern, which has 2 patterns, which is a fibrotic pattern and non-fibrotic pattern. The non-fibrotic pattern is the acute in the acute illness, which shows central lobular nodules, patchy ground glass, and mosaic attenuation. The fibrotic disease shows peribronchovascular fibrosis and an upper and mid zone distribution with associated mosaic attenuation and traction bronchiectasis. So coming to the next important step, what all you will suspect when you have certain specific patterns. If you have a usual interstitial pneumonia, you should think of IPF, rheumatoid ILD, asbestosis, scleroderma ILD in later stages, hypersensitivity pneumonitis in the fibrotic stages, and fibrotic sarcoidosis. If you have a non-specific interstitial pneumonia, you should think of idiopathic non-specific interstitial pneumonia. You can also think of scleroderma ILD, rheumatoid ILD, drug-induced ILD, and smoking-induced ILD. If you have an organizing pneumonia pattern, you think of idiopathic cough or IIM-associated ILD. You also think of drug-induced ILD. Certain cases of rheumatoid ILD can also present with organizing pneumonia, and you should also think of vasculitis. If you have a diffuse alveolar damage pattern, you always think of an acute interstitial pneumonia, and especially IIM with MDA5 positivity associated ILD. Acute exacerbation of any of the existing ILDs can also present with diffuse alveolar damage pattern in the CT thorax, ℏ-CT thorax. The hypersensitivity pneumonitis, again we have to categorize into whether it is a non-fibrotic or a fibrotic pattern. Among this, the UAP pattern has a very poor prognosis. The NSIP pattern has an intermediate prognosis. The diffuse alveolar damage pattern has a very, very poor prognosis. And the organizing pneumonia pattern usually responds to immunomodulator therapy and which has a good prognosis. The very important and vital aspect of an approach to an ILD is a multidisciplinary team. The very important aspect of ILD care to take decisions on diagnostic modalities and treatment in certain ILDs. The team should include a pulmonologist along with a thoracic radiologist, with a thoracic pathologist, and a rheumatologist. If you have a UIP pattern in your chest CT, I think we will be discussing specific patterns and what all investigations you should do. If you have coming to the evaluation of UAP pattern, you should think of IPF, and the other investigations which you should do are rheumatoid factor, anti-CCP, think of asbestosis, and you should also think of fibrotic sarcoidosis in certain patients, and you can ask for ACE levels and calcium levels. And if you think of a fibrotic hypersensitivity pneumonitis, then IgG serum precipitants can be evaluated. The UAP pattern is classified into definitive UAP pattern, probable UAP pattern, and intermediate UAP pattern. If there is a UAP pattern in the chest CT and also a UAP pattern in the histology, then it is an IPF. If you have a probable UAP in the CT and you have a UAP in the IPF, UAP in the histology, then it is IPF again. If you have an intermediate in the HRCT but UAP in the histology, it is IPF again. So this table, I think due to lack of time, I would skip, but then you can take a screenshot if you would like to. If you have a non-specific interstitial pneumonia in your HRCT thorax, then you should think of an idiopathic DIP, COP, or a HP. And the workup definitely should include CTD workup with extractable nuclear antigen profile for CTD. If the CT shows organizing pneumonia pattern, then you should again evaluate for RA factor and anti-CCP, extractable nuclear antigen profile for CTD, myositis profile for IIMs, workup for eosinophilic pneumonias, and ANCA workup for vasculitis has to be done. If the CT has a diffuse alveolar damage, then evaluate for acute eosinophilic pneumonia, evaluate for vasculitis with ANCAs, and especially IIM with MDAF5 positive associated ILD should be ruled out. If the CT shows hypersensitivity pneumonitis, it can be non-fibrotic, which is purely inflammatory, fibrotic, which is purely fibrotic, and it can also have a fibrotic mixed with both inflammatory and fibrotic patterns. History of antigen exposure should be ruled out with a detailed history on exposure. Serum precipitants IgG can be done, but it has a lack of well-defined reference values. It cannot differentiate between sensitization and a disease. A bowel lymphocytosis of more than 30% can be helpful in certain conditions, certain population where you suspect hypersensitivity pneumonitis. So the inflammatory hypersensitivity pneumonitis will have central lobular ground glass nodules, air trapping, and mosaic attenuation or ground glassing, which is called as a 3-density pattern. The fibrotic HP will have reticular abnormalities, ground glassing with traction bronchiectasis and bronchiectasis, loss of lobar volume, and honeycombing. RBILD can be suspected in smokers. It is usually predominantly seen affecting the upper lobes as respiratory bronchiolitis, central lobular nodules, patchy GGOs. Certain hypersensitive pneumonitis patients can also have this pattern. DIP can be suspected in smokers and heavy metal fume exposures. Patient has a desquamative interstitium predominantly in the lower lobes with peripheral predominance. GGOs and microcysts are characteristic of DIP. CTD ILD, the most patients with ILD due to CTD are diagnosed with CTD before developing respiratory symptoms related to ILD. ILD can be the first manifestation of systemic autoimmune disease in a small portion of individuals. Idiopathic inflammatory myopathy, for whom ILD precedes signs and symptoms of myopathy in 7.2 to 37.5% of patients. What is the role of lung biopsy? When will you opt for it? Currently, less than 10% of patients with ILD undergo lung biopsy. In the absence of connective tissue diseases and or exposure of environmental factors known to induce hypersensitive pneumonitis, you can think of lung biopsy. You can consider lung biopsy. HRCT imaging features reveal patterns that are in conditions where HRCT imaging features reveal patterns that are indeterminate for UAP or otherwise, you can consider lung biopsy. Histopathological features, usually by means of lung biopsy, may be required in these conditions to make an accurate diagnosis. Comparing the transbronchial cryobiopsy versus surgical lung biopsy, the yield of transbronchial cryobiopsy is 80%, whereas the yield of surgical lung biopsy is 90%. The complication rate of transbronchial lung biopsy is 9%, where surgical lung biopsy is 6%. The complications include pneumothorax and bleeding. Considering the complexity in surgical lung biopsy, the recommendation is currently in favor of transbronchial cryo lung biopsy, considering it's less invasive and less expensive. The contraindications are similar to SLB. Severe lung function derangements, FVC less than 50%, DLCO less than 35%, moderate or severe pulmonary hypertension with pressures more than 40 millimeters of mercury, uncontrollable bleeding risk, and hypoxemia of PaO2 less than 55 to 60 are associated with very high risk of adverse outcomes when you do a transbronchial cryo-lung biopsy. Coming to the IPF algorithm, patient suspected of having IPF, if there is a potential cause or associated condition, then confirmation of specific diagnosis with HRCT is done. If there is a confirmation for a potential cause and associated condition, then an alternate diagnosis is made. If there is no potential cause or associated, then we go for the HRCT pattern. If it is a UAP or probable UAP, we go for a multidisciplinary discussion, and then we decide on bowel or TBLC or surgical lung biopsy, and then again we go for multidisciplinary discussion. And if it is a UAP pattern, we consider it's an IPF. Or if it is an indeterminate for UAP or alternate diagnosis, the diagnosis is made using transbronchial cryobiopsy or surgical lung biopsy, followed by MDD, and an alternative diagnosis is achieved. Functional assessment of ILD patients are done with PFT like spirometry, which shows restrictive pattern. A 5% or greater loss of FVC over 3, 6, and 12 months is associated with poorer prognosis compared with the loss of FVC less than 5%. DLCO shows impaired diffusion. Oscillometry can also be used, which shows changes in the X5 values. 6-minute walk distance is routinely used, which shows decreased exercise capacity. Cardiac evaluation is must in all interstitial lung disease patients. With 2D echocardiogram is mandatory in all ILD patients, which is used to assess the pulmonary pressures and right heart dynamics. In the increase RCT trial of 326 patients with ILD and pulmonary hypertension, the inhaled prostacyclin analog treprostinil increased the 6-minute walk distance at 16 weeks. Coming to the treatment aspect, if the diagnosis of IPF is made, the treatment considerations include pharmacological components like nintedanib and pirfenidone. The non-pharmacological treatment includes oxygen supplementation if there is hypoxemia and pulmonary rehabilitation. Comorbidity should be addressed. I will discuss in the later slides. And monitor for disease progression. Consider pulmonary function testing and 6-minute walk test every 4 to 6 months or sooner if clinically indicated. Consider annual HRCT if there is a clinical suspicion of worsening or risk of lung cancer. Consider an HRCT if there is a concern for an acute exacerbation. Consider CT pulmonary angiogram if there is a clinical concern for pulmonary embolism. Acute exacerbation you can treat with corticosteroids. Respiratory failure due to progression of IPF, evaluate and list for lung transplantation or suggest palliative care. Coming to CTD related ILDs or systemic autoimmune rheumatic diseases, the first line therapy will be discussed here. In systemic sclerosis, the first line therapy can be MMF, tocilizumab and rituximab with additional options of cyclophosphamide, nintedanib and azathioprine. But one thing which we have to remember when you are treating a systemic sclerosis patient is there is a strong recommendation for not to use glucocorticoids in systemic sclerosis, considering the high risk for renal crisis. For myositis, mycophenolate, azathioprine and rituximab can be used with additional options of JAK inhibitors or cyclophosphamide. Short-term glucocorticoids can be used in this group. For mixed connective tissue disorders, similar to myositis, mycophenolate, azathioprine, rituximab can be used. Cyclophosphamide can be used in these group as well. Rheumatoid arthritis, also mycophenolate, azathioprine, rituximab. Sjogren's, similarly, mycophenolate, azathioprine, and rituximab can be used. An additional option of cyclophosphamide can be used in all these subsects, and short-term glucocorticoids are allowed in these subsects except for systemic sclerosis. Coming to what is progressive pulmonary fibrosis in a patient with ILD of known or unknown etiology other than IPF who has radiological evidence of pulmonary fibrosis. PPF is defined as at least 2 of the following 3 criteria occurring within the past 1 year with no alternative explanation. One is worsening of respiratory symptoms. Second is physiological evidence of disease progression, either of the following, which is absolute decline in FVC of more than 5% of predicted within 1 year follow-up, or absolute decline in the DLCO of more than 10% predicted within 1 year follow-up. Or there can be a radiological evidence of disease progression with 1 or more following: increased extent or severity of traction bronchiectasis or bronchiolectasis, new ground glass opacities, new fine reticulation, increased extent or increased coarseness of reticular abnormality, new or increased honeycombing, increased lobar volume loss. So this criteria is used to establish a diagnosis of progressive pulmonary fibrosis. PPF treatment, conditional recommendation for nintedanib in patients with PPF based on two major factors where there is a statistically significant reduction in disease progression measured as the annual decline of FVC and the adverse events which happened due to nintedanib are reversible with the discontinuation of the medication. Here is an overview of the treatments that can be used for ILD. Nintedanib, which can be used for IPF, PPF and scleroderma ILD. Pirfenidone that can be used for IPF. MMF we already discussed. MMF, cyclophosphamide, rituximab or tocilizumab can all these can be used for systemic sclerosis, Sjogren's, MCTD and rheumatoid. Treprostinil by nebulization more than 9 breaths per session for 4 times per day can be used for ILD associated pulmonary hypertension. Comorbid management, it is very important to manage the comorbidities when you are treating patients with ILD. The very important comorbidities associated with ILD are acute and chronic infections, gastroesophageal reflux, pulmonary hypertension, cardiac disease, pulmonary embolism, lung cancer, obstructive sleep apnea and depression. So the treatment for infection is broad spectrum antibiotic, adjust immunosuppression, prophylactic antibiotics in case of recurrent infections. Gastroesophageal reflux, you can give specific PPIs, H2 receptor antagonist, fundoplication and prokinetics if it is not settling with the oral therapies. Pulmonary hypertension, treatment of the contributing factors. Antipulmonary hypertension treatment is not recommended in IPF, but combination of antifibrotic agents and with targeted therapy for pulmonary hypertension can be considered. For cardiac disease, combination of immunosuppression and antipulmonary hypertension agents in systemic sclerosis related ILD and immunosuppression when necessary. Specific pharmacological treatment for cardiac disease can be done. ICD implantation mainly in sarcoidosis can be considered. Pulmonary embolism, anticoagulation can be done. Avoid vitamin K antagonist in IPF. Obstructive sleep apnea can be treated with CPAP and follow up for check compliance and adherence. Depression, the role of antidepressants is under the debate and pulmonary rehabilitation can be given for patients suffering from depression. It is seen more than in 20% of patients in ILDs and 11 to 50% of patients in IPF. That's quite a lot number for IPF. Pulmonary rehabilitation, 2021 Cochrane meta-analysis of 16 studies that included 675 people with symptomatic breathlessness due to ILD showed that pulmonary rehabilitation was associated with an improvement in 6-minute walk distance of 40 meters compared with control. 102 pulmonary rehabilitation was associated with improved symptoms of dyspnea and improvement in health-related quality of life. Supportive care is very important while treating patients with ILD. Vaccination with flu vaccine, PCV and PPSV23 is recommended. Ambulatory and continuous oxygen therapy are important treatments for patients with advanced ILD. The prospective 2-week crossover study that compared ambulatory oxygen to room air in 84 individuals with fibrotic ILD, oxygen was associated with clinically meaningful improvement in quality of life. 24-hour oxygen therapy is appropriate for patients with ILD who have resting oxygen saturations consistently less than 90%. Coming to cough and dyspnea. Cough and dyspnea are common in patients with fibrotic ILD and both symptoms impair quality of life. Nalbuphine and opioid agonist-antagonist reduced objective of cough frequency. Morphine reduced awake cough frequency by 39.4% compared with placebo in a 2-week crossover study. Benzodiazepines can improve acute dyspnea and panic episodes in individuals with end-stage disease. However, randomized control trial evidence is mixed regarding the benefit of this class of drugs. Coming to lung transplant and ILD, the timing for referral and timing for listing is quoted here. The timing for referral is basically if they have a histological pattern of UIP, then it is a time to refer. Radiographic probable or definite UIP pattern can also be considered as a time for referral. FVC less than 80% or DLCO less than 40% predictive. Relative decline in pulmonary function over past 2 years of FVC more than 10%, DLCO more than 15%, FVC more than 5% with symptomatic or radiographic progression. Any resting or exertional oxygen requirement. For inflammatory ILDs, disease progression despite of treatment can be considered as timing for referral. For timing for listing, hospitalization for respiratory decline, pneumothorax and acute exacerbation, desaturation of less than 88% on 6-minute walk distance, and more than 50 meters of decline in 6-minute walk distance over 6 months. Pulmonary hypertension on right heart catheterization and echocardiography can be considered as timing for listing. Absolute decline in pulmonary function over past 6 months despite appropriate treatment. For time of referral, it is past 2 years, but if the decline is in the past 6 months, which is FVC more than 10%, DLCO more than 10%, and FVC more than 5% with radiographic progression, then it is time to list the patient for transplant. Summary: diagnosis of interstitial ILD. You do a thorough clinical history and clinical examination, initial assessment with chest radiography and spirometry, confirmation of ILD with CT thorax, serological testing for autoantibodies and serum specific IgG antibodies. A multidisciplinary team assessment is done by members of pulmonology, radiology, and if required, pathology and rheumatology. If the diagnosis is confirmed, then we go ahead with assessment and treatment of ILD. If the diagnosis is unconfirmed, then we do an invasive testing, either a bronchoscopy with bronchoalveolar lavage, cryobiopsy, or a video-assisted thoracic surgical biopsy. A multidisciplinary team assessment is again done with members from pulmonology, radiology, pathology, and rheumatology. If the diagnosis is confirmed here, then they go for assessment and treatment of ILD. If the diagnosis is still not confirmed, they go for unclassifiable ILD. Once all these go into assessment and treatment of ILD, we assess disease severity by pulmonary function test and 6-minute walk test. And we also exclude complications using echocardiography, overnight oximetry, or polysomnography. Then the treatment is based on ILD classification. If it is idiopathic pulmonary fibrosis, we go ahead with nintedanib and pirfenidone. If it is systemic sclerosis ILD or other CTD, then we go for immunomodulatory drugs. If it is hypersensitivity pneumonitis, then we go for antigen avoidance or immunosuppression. If it is a progressive pulmonary fibrosis, we go ahead with nintedanib. Treatment for disease complications like rehabilitation, pulmonary hypertension can be considered. If there is a respiratory failure, long-term oxygen therapy is advised. If there is an end-stage lung disease, then consider for lung transplantation. Management of symptoms for cough and breathlessness has to be considered. Thank you.
All right. Thank you, Kaushik. I know it's a marathon job. How do you summarize interstitial lung diseases in 20 minutes? I believe you've done a fantastic job because you've touched upon all the important aspects of ILD management.
No, I'm sorry. I know I was a little fast, but then I have to.
Absolutely. I know. ILD, it's a huge topic, and you really did a really good job finishing it in 20 minutes. So can I have the panelists' slides, please? The support team, the tech team. Can I please introduce my panel now? So by the time you do that, is the tech team around? Can you please share the introduction slides? It's not visible. Yeah. No.
Yes.
All right. So we'll be taking this forward, and we have a panel discussion now on the management of interstitial lung diseases, and we've already got close to 20 to 30 questions that audience have asked already. So everyone, roll up your sleeves, have something to drink and eat, because this is going to really get hot. So I have a fantastic panel with me today. I'll introduce all of them, and then we can start with the questions. We have Dr. Mahendra from Kavedia from Pune. Sir was the organizing chairman of the brilliant NAPCON Pune, which was organized recently. Sir is a postgraduate teacher at Pune and is the principal investigator for a number of trials involving the common respiratory diseases. You're welcome, sir. Next slide, please. Great pleasure to introduce Radha Mujhe ma'am. Needs no introduction. Ma'am is a senior professor, head of pulmonary medicine at Nagpur. She's there in all international and national conferences, doing all of us proud. A fantastic teacher, and always a pleasure to interact with you, ma'am. Thank you so much for being here today. Thank you. And I'm not going to read through your, that will take all evening. All right. Then we have Shrija with us. Shrija is a consultant pulmonologist, and Shrija has trained from Delhi. And Shrija is an associate professor in charge of a lot of labs at MGM Navi Mumbai. So Shrija is basically a Delhiite who is rocking it in Mumbai. Welcome, Shrija. Thank you so much for being here.
Thank you,
Next slide,
sir.
please. And then we have Amina. Amina is a dear friend. Amina and me, we work a few kilometers apart. Amina is a senior consultant pulmonary medicine at the Premium Max Saket Hospital in Delhi. And always a pleasure to interact with you, Amina. Thank you so much for being here today. Thank you. I know you've not been keeping well and still you've been here. Thank you so much.
Thank you, sir. And now it's my pleasure to introduce Arjun, who is leading this panel discussion in the role of moderator. And he's head of the department and senior consultant of pulmonary medicine at the newly opened Amrita School of Medicine at Faridabad, Delhi. And he is a fellow of interventional pulmonology done in Bangkok, Thailand. He has earlier even worked in New Delhi. And of course, I'm not going to read your whole CV, Arjun. But yes, you two are a star faculty everywhere that we see, and even in the recent ICS organized ERS update. So over to you now. You have to lead the panel discussion.
My
It's an
hospital,
absolute pleasure and joy to be with you.
Sure, ma'am. My hospital always gets introduced as the new Amrita Hospital. It's now 3 years old, and it's now the old Amrita Hospital. So, and then another thing is that
we will be adding 3-year-old Amrita.
3-year-old Amrita Hospital now, yeah. Another thing that keeps getting added on is this interventional pulmonology thing. The only intervention that I do is a bronchoalveolar lavage. Even that I suck at. So, anyways, ma'am, I'll start with you. So a lot of questions we've got and a lot of questions that, we've already prepared. But very interestingly, ma'am, we presented our data on interstitial lung diseases a couple of years ago. Very shocking. 60 patients data we presented. Out of the 60 patients that came to a pulmonologist, 58 out of 60 were in respiratory failure. 100% of them were diagnosed as COPD or asthma to begin with and were on bronchodilators and drugs like montelukast with levocetirizine. Out of the 60, 42 people had been given ATT. And that is the sad truth of interstitial lung disease management in our country, that it comes to a specialist very, very late. Now, there are impressionable minds here in this webinar today. There are postgraduate students, there are fellows, and there are young pulmonologists. Any tips or tricks, ma'am? Why do we pick up ILD so late, and what can we do to pick it up early in our clinical practice?
Yes, that is a very, very important question. And for all of us to know, the delay is about 1 year, even in the Western countries, even if a patient is symptomatic. And this delay can be of as many as 4 years also in our country. I must say we must be thankful that during COVID times, thousands of CTs occurred even for walk-in patients. And that is where the radiologists picked up many ILDs, and people have become aware that ILDs is existing to a larger tune, and HRCTs must be looked into details and properly reported. That's one part of it. Second is because the symptomatology is of only tightness in the chest or breathlessness or limitation of exercise or activities. And this, I think, because it overlaps with the common symptoms of COPD that we see. Most of these patients are being treated not only in peripheral clinics, but also in the metros by other doctors. I would not name a specialty, but by other doctors, and are only being treated symptomatically. And once they know that the patient is not getting better or has started suddenly deteriorating, that is the time when the patient is referred to pulmonologists. Even among pulmonologists, Arjun, I hope my fellow colleagues don't mind commenting, but we need to develop, and slowly we have started developing ILD specialists. Like we have IP specialists, we have ILD specialists also, who can really do a good justice to these patients, because the diagnosis is delayed, and from then you need to make a diagnosis of etiology and then go on to treating. Another thing I must also add is that other specialties, or rather say the causative, the etiology of ILD, if it is like, autoimmune disorders, or for example, a patient of sarcoidosis goes to a dermat or an ophthalmologist diagnosed. But rarely do these specialties think about evaluating by HRCT. So I think the time has come that whenever any primary treating specialty or physician has one etiology which is known to cause effect even in the lungs in the form of ILD, that is the right time when referral should happen so that the delay doesn't occur. Another thing, just allow me to take another 1 minute. So Arjun, I know this is getting a prolonged answer. Another thing is when clinically a patient is examined, we must be very cautious that we are auscultating even at the basis. So for example, a patient who comes with breathlessness and you have auscultated, and a busy OPD, you have just auscultated and missed those fine crackles at the basis, those well-cooked reps. So not crackles, sorry. This is the time when we should have actually clinically suspected, because many times the X-ray would be normal and it's only CT which gives you an idea of ILD.
Sure, ma'am. Very
and
well.
Of course, clubbing, and any patient who already has history of rheumatoid or has skin features of systemic or sclerosis and other autoimmune disease, I think that you should suspect.
Sure,
Even
absolutely.
if patient does not have symptoms, patient must be evaluated by HRCT.
Sure, ma'am. And I think we all accept with that. And I always tell my PGs that any patient who has come to you after seeing multiple doctors, or someone who desaturates rapidly on walking, and someone, who's a miserable patient, someone who's not doing well despite being treated with multiple bronchodilators and whatnot, please suspect ILD in them. All right. So, Mahendra sir, interstitial lung diseases in the OPD is probably, one of those patients which is the most difficult to counsel. And when you give them this diagnosis of ILD, this is always, it's like a ticking time bomb. It's something like a lung cancer where the prognosis is going to be bad. And very often patients are going to ask why this. Now, my practice is, because you're a senior and I want, an honest answer from you. My practice is that I am very fond of these interstitial lung disease total panels. ILD complete or HP panel. These panels are now becoming really hot, and what happens is you combine the complete autoimmune profile, the myositis panel, the HP panel, the CRP, and everything gets combined with it. One way of looking at it is that it is expensive, and you end up doing a lot of tests which are probably not required. The other way of looking at it is because this is a disease with a terrible prognosis and you really need to do something fast and you need to have an etiological diagnosis in hand. So go ahead and do it. Is there a correct answer to this? Am I doing right in getting all these tests done upfront? What is your practice and what do you do?
See, ILD is a multisystemic disorder. And if we have to go into the depth of why it has happened, patient will always ask you why it has happened. So basically we have to go into the details of his history. His history taking is very important. How fast the disease has come, what are the symptoms, and what are the occupational history, family history. This is very important in such patients. This history can give you a clue to the diagnosis and you may not need to go for the further test like this. So by the time you have diagnosed as an ILD, so you have already done chest X-ray, routine blood tests, HRCT has absolutely been done, and that you have come to know that it's an ILD. Then you want to find out the etiology or why it is Hopper or what type of it is. So for that, multiple tests are what you have said is autoimmune profile, the myositis. Before that, a patient, we have to take the proper history of the patient, whether patient is taking any insulting drugs like the nitrofurantoin, amiodarone, or busulfan, or rituximab, or any drug which is causing the ILD. Occupational history, whether he's working as a coal miner, work exposure to asbestos, whether he's working in with the silica. So these are very important.
The investigation part, history part is fine. I'm talking about
So
the investigation.
so all these will give you the idea about what you want to investigate, whether the history of any exposure is there, birth exposure is there. So this will give you the idea about where we are heading. So accordingly, you can guide your investigation. We may not need to do all this investigation. Investigation basically, of course, ultimately the HRCT pattern will decide what type of the disease there, how much desaturation is there. But investigation we do not do for all the patients, especially the patients who are not affording all myositis profile and all may not be doing. We'll be doing a simple test like a CRP, autoimmune ANA blot, and that is sufficient.
And once you start interpreting these tests, I'll come to you. One of the most talked about tests is the HP panel, and everyone wants to get these HP panels done. And I'm sure because in Delhi NCR we do see a lot of these HP panels. My problem is always that when you get one of these complete autoimmune profiles, including an HP panel done, you would see Pigeon 2+, Cladosporium 2+, Aspergillus 1+, along with that an ANA which is just positive. And you see this mishmash, multiple positives. So how do you interpret these HP panels, and how do you interpret someone who has an HP panel, say plus minus positive, and there is an autoimmune profile which is cropping up? Does it really add anything to the management of these patients?
No, it does. And thank you so much for asking this brilliant question, because we all struggle with it. So beginning with the HP panel, as we've already discussed, it indicates exposure, but not indeed disease. It does not pinpoint it as the sole cause of ILD. It has a good specificity of around 80%. Having said that, the ATS guidelines do recommend sending the IgG in both fibrotic and non-fibrotic HP when you're looking at them as differentials. Other thing is that you have a fairly positive HP panel. We have a look at the CT scan. If the CT scan is also characteristic of a classical hypersensitivity pneumonitis picture, you can with a fair amount of confidence say that, okay, this is HP. If, the HP panel is not strongly positive, if the CT is not very conclusive, then you go ahead with the second line of investigations like bronchoscopy. You do a TBLB for the non-fibrotic subtype, TBLC for the fibrotic subtype. Now coming to this question of ANA, ANA positivity along with a positive HP panel, so it may be positive in 15 to 20% of patients with HP. However, the clinical relevance of this is like sort of poorly investigated. So it is essential to rule out an overlap. You will take the relevant history. You will see if the history is suggestive of any other CTD, although coexistence is very, very rare. We do a LIA panel, a CTD panel, a myositis panel to check what is the significance of this ANA. In terms of patients who have an HP along with a positive ANA, there is just a prognostic implication, because there is, I think, a German data that says that the progression to fibrosis and the steroid refractory disease would be higher in patients with HP who have a positive ANA.
Yeah, that's something which is very important, and there is data which tells us that. Also, what one needs to remember is that ANA can be a red herring. ANA can be positive due to infections, due to air pollution. It has been seen that up to 25% of people in Delhi NCR, because the pollution is so bad, can have a false positive ANA, just positive ANA because of air pollution. So if you do get them positive together in the right clinical context, these patients may have a worse outcome, as Amina has pointed out, and that is the point that I wanted to really highlight here. So shifting gears from these lab investigations to what we do as pulmonologists, that is the lung function test. Now, Srija, we all would do a routine spirometry, and a lot of us would also add on doing a diffusion capacity in these patients, which is important. DLCO and a good spirometry is important. But is there a role of new lung function tests, body box, IOS, and how do you interpret the 6-minute walk test in patients with interstitial lung disease? Because we all know it is important, but somehow we don't do it as often as we should be doing it. So your take on that, Srija?
Yes, thank you, Arjun, for the question. And thank you, ICS, I just want to thank everybody for giving me this opportunity. So coming to the question, yes, lung function test, there's a question in the chat box that showed, can we diagnose ILD with lung function test? No, actually, we don't use it for diagnosis. All these tests, including spirometry, DLCO, TLC, the 6-minute walk test, these are all prognosticating factors, and they help as a way to find out whether the treatment works and to help prognosticate the patient, how they're going to do in the next 6 months to 1 year. So every patient who comes to us in the OPD, we must do a baseline SpO2. We should check the saturation and then do a 6-minute walk test. So the 6-minute walk test, what we're seeing in this is that the distance the patient walked and also the fall in oxygen. So from the baseline, if there's a 4% drop in the SpO2, or if there's a drop of more than 90% at any point during the 6-minute walk test, it is significant and it is a poor prognosticating factor. So it's a sign that the patient does have evidence of fibrosis, and these patients will most likely go on long-term oxygen therapy if we don't start the treatment early. So 6-minute walk test should be done ideally every OPD visit that the patient comes, and we can use it as a prognostic tool. Many trials have used 6-minute walk test in pulmonary rehabilitation, also for many treatment modalities to see the response to the treatment. So apart from, we all know that FVC and DLCO are a must. We have to see the decline in FVC every 6 months to 1 year. So less than 5, as Dr. Kaushik already said, a 5% absolute decline in the FVC and a 10% absolute decline in the DLCO is significant. Yes, but we should also, what we can add on to this pulmonary function test is a body box, because TLC is how we, say that the patient does have restriction, and that is more sensitive than the other methods such as helium dilution, nitrogen washout. So definitely we should do once a TLC, and also that when we do a body box, we can also get a more, information about the residue volume, the vital capacity, the tidal volumes, even the airway resistance. All that can be found out with the body box, and along with that, we can do the TLCO side by side. Now, when it comes to IOS, lung oscillometry studies have been done. Recent one I read was by Lopez et al. It was a Spanish study which was done in 2023, in which they evaluated about 45 patients of ILD with fibrosis, and they found that there's a strong correlation of reactants X5 where there's more where the inspiratory reactants X5 is more than the expiratory, and they found a strong correlation in X5 with DLCO and FVC. And another thing the IOS can help us with is in patients, of course, who cannot perform spirometry. So patients who have difficulty in performing the FVC maneuver, who cannot hold their breath for DLCO, such patients will definitely benefit with some form of, a pulmonary function test, and that could be in form of IOS. And even patients who have evidence of small airway disease, so patients with HP, eosinophilic pneumonia, COP, such patients we can find in the resistance R5 minus R20 can also give us some light in the treatment. So this is my take on the
I think we need to do the body box more, because as you very rightly said, TLC is the best, the total lung capacity is the best outcome that tells you there is restriction or not. And why I use a lot of body box in patients with interstitial lung diseases is because this gives you the RV by TLC, and this tells you if the residual volume is high, because a lot of these patients have concomitant obstruction. So diseases like sarcoid or HP, which start from the airways and then spread to the periphery of the lung. When you have a high RV by TLC, and when you do their body box, and when you show there is a bronchodilator reversibility on a body box, the RV by TLC going down, these patients do benefit when you give them bronchodilators. So don't just stick to your standard PFT with diffusion. Look beyond PFT with diffusion. Do a 6-minute walk test. If you have access to IOS and body box, please do it. There's absolutely no harm in doing it. And one question that I'm getting again and again is in the panel. I'll take that if the CTD panel is negative, the ANA is negative, can you say that the patient does not have a autoimmune disease related ILD? No, that's not correct. These tests can be very dynamic. Someone who's ANA negative now may be ANA positive after 6 months. So if you have a strong clinical suspicion, you need to repeat these tests again and again. A lot of our rheumatology colleagues would say that ANA is the mother test, and if the ANA is negative, then in more than 80% of the patients, the ENA or the slip LIA, the washdown tests are going to be negative. But in a few patients, if the clinical suspicion, you suspect something like scleroderma clinically, or you suspect something like MCTD clinically, and the ANA is negative, you can go ahead and do the full-blown CTD profile. You just might see some antigen turning out to be positive. All right. So I'll ask, after my panelists have spoken, I'll ask, because Kaushik took this talk, and I'll ask Kaushik to sum it up. Kaushik, now we have talked about all kind of investigations, pulmonary investigations for interstitial lung disease, but nothing comes in silos. When you treat a patient with interstitial lung disease, a lot of these patients will have diabetes, heart disease, other comorbidities. So what is the basic set of investigations that a pulmonologist is supposed to do, non-pulmonary investigations in patients with ILD before you start their management? Yeah. Is Dr. Kaushik there?
Yeah. Can you hear me? Yeah.
Yeah.
So, Dr. Arjun, I think I would split this question into two parts. One is after diagnosing the ILD, if you're going to start the... I think some other mic is on.
Yeah.
Okay. 10:30 Okay.
Yeah. So I would like to split this question into two parts. One is for diagnosing ILD other than UIP pattern. I think there are a whole list of investigations that you would like to do to confirm if it is a CTD or not, or if there is a myositis or not, like muscle biopsy, or if you want to do rule out Sjogren's, then you do a lip biopsy, you do ophthalmic examination, then you do a Nile fold capillography. Some patients of scleroderma, you could also do esophageal motility studies. And if you're suspecting sarcoid, you would like to do ACE levels and calcium. You can also do muscle enzymes levels and everything. So the second aspect is, once you confirm, and if you're going to start the patient on antifibrotic or immunosuppressant or immunomodulatory therapy, then probably you have to do a whole blood work, especially to rule out infections. And like you rightly said, you have to also know if the patient is diabetic and if it is totally under control. And we should also rule out latent tuberculosis in these patients using MANTU or an IGRA. And definitely liver functions and renal function has to be done, because most of these drugs will have some kind of side effects that can cause liver or renal injury. I think that's as basic as possible, and definitely a cardiac evaluation with a 2D echocardiography. And then if possible, in certain cases, you can also do a right heart cath. So I think that I would sum up with this, like you have two parts. One is for diagnosis and second is before starting therapy. Yeah, that would be my...
Fabulous. I think you've really summed it well. One investigation that I would add on to this is a sleep study, because I think a lot of these patients would also have, and they desaturate more. So I think it is something that we as pulmonologists need to put more emphasis on.
So but I just took sleep study into the pulmonary this thing. So
you summed it up really well. And thanks, Kaushik. That's really helpful. So I thought I would not be asking this question, but then I'm seeing this question again and again, and I think Radha ma'am is the best person to do this. Ma'am, I think a lot of PGs have logged in, and everyone is asking about CT, and how to interpret a CT. Now, interpreting a CT in ILD is going to be a 5-hour class. Is not going to be possible. So, ma'am, 5 Guru Mantras, because there are PGs here, and you are a professor, and you probably are going to be their examiner. So just give me 5-liners for I know it's a very difficult job. Just 5-liners for diagnosis, or what a PG needs to see in a CT chest with ILD.
Arjun, I'm sure everybody who is listening, as well as we all in the webinar, would agree. For the first mantra is that your CT should be satisfactory. That means when you are reading for ILD, the ILD protocol must be followed, and you should inform your radiologist. So have a good talk with radiologist so that your patients are screened well, right? So like deep inspiratory, expiratory films, prone whenever needed must be there. Then start with the scout image to get an overview, and catch anything outside in the axial slices also. You should look at that. Then you need to have a structured approach when you look at the patterns, right? So different radiologists and different people have their different ways of interpreting. Like somebody likes to go like whether there is a fibrotic and non-fibrotic, and then they would proceed. Whereas we usually look at the pattern which we see on HRCT, like is it reticular, is it nodular, is it mixed? Then where is it located, the distribution, the upper zones or the upper lobes, or middle and the lower predominantly. Then the subpleural sparing, if it is there or not. All these things you have to pay attention to. Then also differentiate the gravitational changes from true pathology like ground glass opacities. Most importantly, I would always say that whatever findings that you have on HRCT must be correlated in the clinical context, because the patterns would be same for many different things, but depending upon the patient's history and presentation, you have to interpret the findings that you have. So these are the mantras that I would always insist on.
All right, I know. This is going to be an endless discussion, but thank you so much for summing it up. And I have close to 100 questions that have been asked already. I'm so sorry, I'm not going to be able to take up all of them. So I'm going to try and skim through the most important ones that are relevant.
And I have purposefully not gone to the presentation seen on
I know,
CT.
ma'am. That's not
Like how the UIP looks, the NSIPs, the
Sure,
DIPs, and so on.
understand that, ma'am. Absolutely. So, Mahendra sir,
It
management
would
of
be difficult to explain without a picture in hand, you know.
Sure, ma'am. So, Mahendra sir, the
But
management
yes,
of LD.
honeycombing, traction bronchiectasis, apart from all findings, must be looked into very well.
Sure, ma'am. So when you start the management of interstitial lung disease, the treatment per se, if I could sum it up in one word, is steroids. Obviously not for IPF, but for non-IPF ILDs, which would be a large population, for our patients. So steroids, choosing the right dose of steroid in patients with interstitial lung disease. Do you have a favorite steroid, or is there any evidence to tell us that, prednisolone is better than deflazacort or methylprednisolone? What dose of steroid? How do you taper them? How long do you continue? Do we have any guidelines or any evidence to support what we do in clinical practice with steroids? Mahendra sir. Sir, you need to unmute. Unmute, please.
Yeah, sorry. As you correctly said, steroids are not the drug for the IPF, but whenever it is a non-IPF ILD, especially the autoimmune ILD or connective tissue related ILD, like rheumatoid arthritis related UIP or ILD, there the role of steroid is there, where there is a inflammatory driven ILD, which will be helpful, which will respond to the steroids. The usual dose is around 0.1 to 1 milligram per kg body weight. That should be continued for at least 3 to 6 months, at least 3 months. And then you can go on tapering depending upon the symptoms, and for a period of 9 to 12 months. Now, another set of ILDs where the steroids are used are the hypersensitive reaction, hypersensitive pneumonitis in the early stage when there is a lot of inflammation. There also, to suppress the inflammation, you can use steroids. Usual doses, but you may not give for a long period of time. Usually it is for the 4 to 6 weeks, and then you can start reducing the dose, taper the dose to the minimal required, maybe for about 24 weeks or so, 6 months. And the maintenance dose, if required, can be continued. But if it is a fibrotic hypersensitive pneumonitis, then the steroid should not be used. It can be worsen the disease. Then another case, and another case like a sarcoidosis, or when there is sudden deterioration in the non-IPF ILD, then that is the time we can use the pulse steroid therapy. That is one important thing, where you can use in a high dose like 500 or 1 gram over a period of daily for about 3 days or 5 days to get the patient back to prevent patient from going into the ventilators.
Sure, absolutely. And this is something that everyone talks about. So all oral steroids are more or less same. Deflazacort is supposed to have lesser metabolic side effects, but we rarely see that in clinical practice. I think most of them do have the same set of side effects. And the usual dictum is the least possible dose for the lowest duration. And steroids, unfortunately, have had a really bad press after COVID, and people would be very wary of taking steroids. And the first question is, "Kab tak lena padega? Sari umar lena padega?" And then people have their issues with steroids. So what I tell them is that this is one of those diseases. If you don't, you're going to die. So it's better you take them and you educate yourself about the side effect of steroids, and you tackle them, side by side, rather than saying that steroids have a lot of side effects. We understand they do have a sort of side effects, but it's the effects that we are talking about which are more important. And because when you talk about steroids, you always talk about steroid sparing therapies. So Amina, a lot of steroid sparing therapies are available: MMF, azathioprine, HCQS, leflunomide. Do you start them upfront with steroids? Is there some kind of a flowchart which is to be followed that, or are there any patients where both of them can be co-started? Or would you want to start a steroid-sparing agent, something like MMF first? You have, say, diagnosed sarcoidosis, or you have diagnosed something like a rheumatoid-associated ILD. Would you want to start them on steroids, or is it okay to start them on something like, say, MMF or azathioprine upfront? What is your take on it? What does the evidence say regarding this?
Right, sir. So we have very wonderful guidelines by the American College of Rheumatology, which were brought out in 2023, that have clearly specified that these steroid-sparing agents can indeed be started as the first-line therapy in patients with CTD ILD, and MMF in the last few years has really emerged as the star drug for a lot of CTDs. So whether it is systemic sclerosis, whether it is diseases like myositis, even MCTT, Sjogren's, even in RA, and of course hypersensitivity pneumonitis, the dose would be 250 to 500 to begin with, and then you gradually titrate up. So it is very clearly mentioned that you can start a patient on these steroid-sparing agents as a first-line therapy, and then of course if needed you can add glucocorticoids. Azathioprine, again, all of these indications, even sarcoidosis, you can use azathioprine, though Folitrax remains the first choice. HCQS is not now recommended as a first-line therapy, but the indications might be, sarcoidosis, again, myositis, and even rheumatoid arthritis. When it comes to the other steroid-sparing agents like leflunomide, not really mentioned anywhere now, may be used in sarcoidosis. SARS is also mostly out. The newer kids on the block, of course, we are going to discuss subsequently, like Tocili and Rituxan, tofacitinib. So to summarize it, basically using the steroid-sparing agents upfront is a reasonable approach, and the seniors can correct me if there is anything else that they'd like to add. But as far as the guidelines go, you can definitely use them upfront.
Absolutely. So, a lot of patients would come to you where you make the diagnosis of this sarcoid with diabetes, and you're really scared of starting this patient on, say, 30 milligrams or 40 milligrams of Omnacotil, because the diabetes is going to really be thrown off track. So there is now very good evidence, as Amina has already talked about, that especially with CTD ILDs, although the data is limited, with CTD ILDs, with autoimmune featured ILDs, the data is there. But with sarcoidosis and with HP, the data is not that heavy. But yes, there are case reports, there are case series wherein patients have been started on upfront immunosuppressives rather than steroids, and the outcome has not been worse than steroids. So that is food for thought, and that is something that can be done in a lot of our patients. So, anti-inflammatory therapy is one part of it. Then the second part of it is the anti-fibrotic therapy. Shrija, I'll ask you this. So how do you go about this? So can patients be started on both anti-inflammatory therapy and anti-fibrotic therapy upfront? I get a patient today in my OPD, he has a really bad ILD, and I, want to give him everything possible. So am I correct in starting this patient on, say, 40 milligrams of steroid along with nintedanib or pirfenidone? And when it comes to the antifibrotics, is there a clear winner between the two? How do you choose between the two? And I know it's a big question, but your take on it, Shrija.
So when we're talking about antifibrotics, yes, we're talking about pirfenidone and nintedanib. So it's been there are clear-cut indications to start these antifibrotics. So the indications are, of course, in IPF, progressive pulmonary fibrosis, and systemic sclerosis in ILD with evidence of UIP pattern. So in such patients, yes, upfront, the earlier the better is what the dictum says now. So because we do know that these patients who have evidence of UIP, and as per studies, it's shown that even the ones with baseline lung function of FVC more than 90, even their decline is kind of equal to patients who have a worse lung function. So it is always better if there is evidence of UIP in such patients. Definitely, you can start it upfront with the other agents that you were talking about. And the other thing is, yes, in the inbuilt study that has been recently done, it has been broadened now. We can use nintedanib in chronic HP, and we have been doing it. So in indications such as rheumatoid arthritis, ILD, chronic HP, in such patients, I suppose we can monitor. And if we see that the decline of the FVC and the DSU kind of matches the PPF, the progressive pulmonary fibrosis, then definitely we should start upfront and monitor the patient. Now, which molecule to choose? I think nintedanib has more studies have been done in nintedanib as far as a variety of ILDs have been, are concerned. But it all depends on the pill burden, the side effects that the patient can tolerate. So I think one thing we have to tell patients who are severe ILDs, PPFs or IPF or, UIP pattern ILDs, we have to tell them that, of course, you have to enroll for lung transplantation. We are starting this, but we don't know if you will be able to tolerate it. So the side effect profile can be worse in patients with, severe lung function. So this has to be told upfront that they might not be able to take up to the maximum dose of pirfenidone, and they might not tolerate the GI side effects of nintedanib. And so I think we have to say it with a word of caution, but I would say the earlier the better in cases of a frank UIP pattern ILD.
Sure. So I think the indications of starting it upfront would be, as you very rightly said, IPF, a frank UIP, and someone who comes to you with, say, PPF. And of course, if the patient has scleroderma ILD. So in scleroderma ILD, starting antifibrotics upfront is the dictum. And this is one disease where the outcome is probably going to be even worse than UIP and than ILD, the classic IPF. So it is very important and very pertinent that we always talk about GI side effects, and these patients, when you start both the drugs together, you need to be very careful. Take care of the GI side effects, but you need to give the patient upfront antifibrotics if the lung disease is really bad. Kaushik, summing up the data on antifibrotics. Shrija was talking about the INBUILD trial. What is the evidence? What does the evidence say regarding nintedanib and pirfenidone? Is there a clear winner? Can we start both these therapies together, if at all? Or how do you choose between the one or the other in your clinical practice? You need to unmute.
So Arjun, I think going by the available data, I think there is not much of studies which have done head-to-head comparison between pirfenidone and nintedanib. There are a couple of studies available in which one study there is no superiority proven. Both drugs are of similar effect, but there is one study which is cleanup IPF study which shows that nintedanib had a superior benefit at the end of 12 weeks. It had an improvement in FVC somewhere around 100 to 104 ml, but then it failed to achieve the same when it was in the 24-week. It almost attenuated its effect, and then it's almost similar to pirfenidone. But where nintedanib clearly wins is, like we discussed, systemic sclerosis related ILD and then progressive pulmonary fibrosis. I think your drug of choice would be nintedanib rather than pirfenidone there. So, and then, but clear cut what to choose for which patient is still a big question to be answered. And I would think we'd go with the side effects based therapy as of now. So that would be my take on this.
Absolutely. And I think most of us are now, biasing towards nintedanib. And pirfenidone comes with its unique set of side effects, the pill burden, which though is going down. We have the 800 milligram tablet now available. But I think it's generally an unpleasant drug.
But in few cases, I think we have also swapped from nintedanib to pirfenidone because of side effects. Yeah. Absolutely. So that can also be there.
Absolutely. Diarrhea is so common with nintedanib. And so it's both ways. One thing about switching is that nintedanib is a slow acting drug, pirfenidone is a slower acting drug. So when you shift a patient from nintedanib to pirfenidone, you risk an exacerbation. So whenever a patient is being shifted from nintedanib to pirfenidone, please be very careful. Probably you need to hike up the immunosuppression at that time. That same risk is not there when the patient is shifted from pirfenidone to nintedanib, all right? So shifting gears from pharmacology to non-pharmacological management, and I'll go to Radha ma'am for this. And ma'am, COPD, ILD, everyone talks about pulmonary rehab. It's a very important long question, and everyone, is very fond of it. It's a very fancy thing to do it. It sounds very nice to talk about in conferences. And when you really come to the bottom of it, ground reality is, people would say, I don't have a pulmonary rehab in my unit. I don't have a CPET machine. I don't have a dedicated pulmonary rehab specialist in my hospital. How do I do this rehab? So your take on it. I don't have access to a lot of stuff. What can I tell my patients?
Yes, that's one of the wonderful questions. And basically we have to understand that the best thing that we can ever offer a patient of any chronic lung disease, including the interstitial lung disease, is the pulmonary rehab. So it would, apart from the drugs that you are giving to slow down the fibrosis or a progress of disease, or the immunomodulators, it is the pulmonary rehab which is actually going to give a good quality of life to the patient, as well as increase patient's exercise tolerance. Agreed that we do not have dedicated pulmonary rehab programs, as do most of the cardiologists have for post of care for their cardiology patients. The best thing is that we connect the patient. If you do not have it in-house facilities, the best would be to connect the patient to the nearest pulmonary rehab center, which is nearest and approachable for that particular patient. And when such patients are referred, it's good that you write a complete diagnosis, what patient is getting and what you would like him to be trained for. And we all know that for any chronic lung disease, diaphragmatic strengthening exercises are important. Apart from that, all these things, even if we do not have we do have obese patients who have ILD, but still in spite of that, you need to have girdle strengthening exercises also, upper as well as the lower girdle. And this is not all. Everybody thinks that pulmonary rehab is a physical exercise or a physiotherapist which you need. No, that is one component of it. Other components are equally important. And here I must emphasize the first and foremost is that patient should not have sustained hypoxia. So wherever indicated and whichever patient needs, they should be put on long-term home-based oxygen therapy. Or if they are desaturating during exercise, that is not a limitation to do a physical exercise, but they should use oxygen and continue with their treatment plan of physical exercise. Then vaccination is very, very important. Nutrition is very important. And parallelly to all this, I think the third group is counseling, which is needed from the treating doctor, as well as if patient has depression or anxiety, or if the drugs are changed, or if patient has exacerbation in between, they can even go to a trained counselor for counseling. And here also, you need to have some bridges with those people, like let them know what type of disease this is and what are we expecting in the future. And of course, the vaccination. Did I comment on vaccination?
Yeah, yes.
So vaccination is very, very important. And
so good, no, ma'am. This is so important because none of the medicines per se, if I eat a medicine, it should work. If I eat paracetamol, the fever should come down. The problem with ILD is when you give them nintedanib, when you give them pirfenidone, there is no clinical benefit. Doctor, my cough is the same, my breathlessness is the same. But when you talk about exercise, when you give them protein supplementation, when you talk to when you do some kind of counseling, when you give them anxiolytics, antidepressants, it makes a huge difference in their life. So just because you don't have an exercise capacity does not mean that you will not do it.
Yes, and you need to address their comorbidities also. These are likely to have hypertension, diabetes, OSA, and GERD, which is also a very common comorbidity associated. So all these must be tackled.
Absolutely. It has to be very comprehensive.
And another thing is, this is not only about the quality of life, which of course every doctor wants to give to their patient, but these are the patients who are actually candidates ahead for transplant. And if they are started with a rehab initially, I'm sure Kaushik and you would be better to comment upon that we have the best outcomes post-op.
Sure, I'm sure. So Mahendra sir, once the treatment has been started and the patient starts coming to the follow-up OPDs, what is the ideal duration of repeating a CT chest? Do we need to do it every year? Do we need to do it every 6 months, or chest X-rays are good enough? And how often should we be doing lung function testing, blood tests? If an autoimmune profile is to be done, should we be repeating it? So what is the ideal OPD follow-up of these patients? How often should we be repeating these tests? So you need to unmute.
Yeah, good question. Once the follow-up will depend upon the severity of the disease, progression of the disease, and the type of ILD. If it is stable ILD for many years, many months, then the regular follow-up should be after every 3 months. If it is a progressive ILD, then we call patient after 2 months. If there is a rapidly deteriorating ILD, then we call it after 1 month. And the patient who has been discharged of ILD, then we call them after 2 weeks. This is the regular follow-up we have planned in our hospital and our clinic also. And during this follow-up visits, first is the important is the clinical examination for any change in the symptoms, progression of the disease, oxygen saturation, any deterioration in the oxygen saturation, 6-minute walk test, or whatever the exercise tolerance that is assessed clinically. PFTs are done every 6 monthly. ABGs are done every 6 monthly. CT scan only after 1 year, or if there is a sudden deterioration, or we suspect something new has come, or patient is deteriorating, progression or some infection is there. So this is the routine protocol, and inflammatory markers, WBC count, they are done every 3 months. Hemogram, if the patient is on antifibrotics, then LFTs, KFTs are done to assess for the side effect profile of the antifibrotics. So routine hematological profile every 3 monthly if patient is on antifibrotics, and PFT every 6 monthly, CT scan every yearly for a stable patient.
Very, very nicely summed up, sir. And I think these patients would come to you with a bundle of CT scans, which I very often tell them that it's not required. A follow-up should be ideally done. Just, 6-minute walk test is such a valuable test for follow-up, which we don't do. So rather than a CT telling you anything extra, a simple test such as a 6-minute walk test would be really helpful. And you've really, summed it up very well. Now, a lot of PGs here in the audience today, and for these kids, PPF is a very important hot long question. So can you sum it up for the kids? What is this progressive pulmonary fibrosis? It comes up with a lot of new names. I don't know, every year they change the nomenclature. This is some kind of a fetish that these guys have. Every year they change the name, and every year these poor kids have to mug up the new definition. So what's the new definition, and how would you manage a PPF guy in your OPD?
So basically, see, PPF is first of all a non-IPF ILD who has radiological evidence of pulmonary fibrosis with at least 2 of the 3 criteria. One is worsening respiratory symptoms. So a non-IPF ILD who has worsening respiratory symptoms, 1 criteria. The second would be a physiological evidence of disease progression. Now, the important thing to note here is that there are 2 things in this, the FVC and the DLCO, and the percentage predicted is what is seen. So absolute decline in an FVC of more than 5% predicted within 1 year of follow-up, or an absolute decline in DLCO more than 10% predicted within 1 year of follow-up. So these are the physiological criteria. And then finally, there is radiological evidence of disease progression, which could be anything. It could be increased extent of your traction bronchiectasis, it could be new ground glassing, new fine reticulation, increased coarseness of the reticular abnormality, increased lobar volume loss. So this is the definition that you have to remember. Now coming to the treatment, Shrija, I think very beautifully summed up the treatment. The mainstay of progressive pulmonary fibrosis would be the antifibrotics. Nintedanib out of the 2 has more robust data. It is recommended as per the guidelines. The pill burden is less. Pirfenidone one could consider if a patient is on anticoagulation therapy, there is there's ischemic heart disease, so on and so forth. Now, if you have a progressive pulmonary fibrosis in a patient who is a case of CTD ILD, then you could also, of course, consider, stepping up or changing therapy. You talk of endoxime, rituximab, tofacitinib, even IVIG if you have myositis. Then, of course, coming to LTOT, the criteria for LTOT by and large are same as those of COPD, so that remains standard. Home NIV in patients who have like a progressive disease and develop type 2 respiratory failure. One more thing to note here is that early referral for a lung transplant is not indicated in PPF, unlike IPF. So in an IPF patient, you would refer for a lung transplant early, but in PPF, you would first look at optimizing therapy and the underlying lung disease. So that's pretty much it.
So 10 marks, Shrija, 10 out of 10. So PGs need to remember all the points. The definition is really important. So 3 parameters, clinical, radiological, and physiological. You need to have 2 out of 3, and the management we have talked about. Now, talking about, taking it forward, management. Shrija, this is for you. patients with ILD, the most miserable patients to treat, because the breathlessness, the cough doesn't go away. So you start the patients on steroids, you start them on immunosuppressive therapy, antifibrotics, you start them on standard run-of-the-mill, antitussives, cough suppressants, but the cough doesn't go away. The sensation of dyspnea doesn't go away. So tell me what a pulmonologist is supposed to do with the patients who have intractable cough. What is the data regarding drugs like gabapentin, drugs like thalidomide? Are there any new kids on the block that can be given to these patients for the cough and dyspnea? Srija.
So thanks, Arjun. So relentless cough is a very troublesome thing for the patients as well as for us. And I think like Radha ma'am had mentioned, we first have to rule out the comorbidities associated before we actually label this as, an end-stage disease with relentless cough. So we have to rule out things like upper airway cough syndrome, GERD, which is really troublesome in IPF. So once we treat the upper airway cough syndrome, GERD, the obstructive sleep apnea, maybe patients could be on ACE inhibitors. We have to deal with that. Is the patient developing lung cancer? So we might have to repeat an HRCT. And so maybe these are the main comorbidities that we have to look at in cough. And if all that is tackled, there are new studies which have shown that thalidomide, one study I've read which has shown that there is a reduction in the observed cough. And but I've never used it as such. Pirfenidone is shown in one study to reduce the cough. So I'm not saying I suggest that we change from nintedanib to pirfenidone, but pirfenidone is shown from the two antifibrotics to have some effect on cough. Nalbuphine, which is a new opioid, is shown to have reduced again cough in patients in one or two studies. And other than that, I think there's a new formulation of sodium chromoglycinate, which is not available in our country, but that is shown to have a reduction of about 30 to 35% reduction in observed cough. So these are some of the agents that we can try. But like you said, it's very troublesome, and we usually try with morphine or codeine Linctus. This is what we usually do, and then address the side effects. Address other comorbidities and try to take it from there. So this is what I've read.
So nalbuphine is what I basically wanted you to point out, because there is now very good data with nalbuphine. Nalbuphine does not have the side effect profile of morphine. Though it is a Schedule H drug, you do not need special licenses to prescribe it. A pulmonologist can prescribe it. There is very good data with intractable cough. If you compare, there is head-to-head comparison of gabapentin with nalbuphine, and nalbuphine is shown to have a much better side effect profile and is much more effective in controlling the cough, the distressing cough of interstitial lung disease. So this is the new kid on the block, amazing data, and this is the drug that we need to read more about. So a lot of PGs here, a lot of young pulmonologists here, please do read about opioids, because in India, we don't use opioids in these patients as much as we should be using. Even tramadol, simple tramadol has been shown to have antitussive effects. I'm not saying that you give tramadol to patients with IPF or ILD, but do think about opioids and read about opioids, because this is very important, right? Kaushik, a lot of patients, a lot of us work at tertiary care centers, and patients are referred to us in acute exacerbations, or patients with really bad PPF attend our clinics where, the patient has already been on steroid, MMF and whatnot. So in these patients, is there any role of IVIG, rituximab, plasmapheresis? Can these patients be started on tofacitinib? I want you to sum up the evidence in these patients. The last ditch drugs, the most ballistic antifibrotic, the anti-inflammatories that we have. What is the data regarding that?
So as far as the data goes, I don't think they have any clear-cut role in IPF exacerbations. But then when it comes to CTD-related ILD exacerbations, I think IVIG has an off-label use where it can be combined with other immuno. Are we on?
Yeah, absolutely.
Yeah. So IVIG has an off-label use when we use it in combination with other immunosuppressive agents, especially for DMPM related ILDs and anti-MDA5 positive rapidly progressing ILDs. Rituximab, as we previously discussed, I think there is a proven, it's proven to improve the FVC in advancedly progressing CTD ILDs and vasculitis related ILD. But there is no significant improvement in the DLCO as such when you see, if you use rituximab in this subset of population. And cyclophosphamide is definitely has a very major role in systemic sclerosis related ILD, which is rapidly progressing. And tocilizumab, I'm not very sure where the data stands for that. So I think for vasculitis related ILD and systemic sclerosis related ILD and advanced and progressing CTD related ILDs, these have very good beneficiary role, Dr. Arjun.
Sure. So I think rituximab and IVIG off-label use, but we have used it quite extensively in our patients, the really bad patients in IVIG, and you have nothing to lose, so you can go ahead and try. There is positive data, and you're not.
Like you said, I think there is also a role for plasmapheresis in these group of patients when you actually prove that it is CTD related ILD with rapidly progressing phenotype.
So sure. So last ditch effort for patients who are really, falling and can be done. So before I take the next question, this question is being asked again and again. So people are asking, Amina, we said that patients can be started upfront on, immunosuppressive therapy, which is steroid sparing agents. And people are saying that these agents take time to act. So I'll just answer that. So whenever if I'm not starting a patient on steroid and I need immunosuppressive therapy, I'm not going to start them on the standard 500 milligrams of BD of mycophenolate. If I have to start the anti-inflammatory therapy with mycophenolate, I'll give the loading dose of mycophenolate, which is 2 grams, which is 2 grams BD for a couple of days. And then the ideal dose is 1 gram BD. Always ensure that whenever you're giving mycophenolate, it is to be taken empty stomach. So you give it either half an hour before food or 2 hours after the food. MMF does not work if there is food in the stomach. And this is one of the most common, prescription errors that I see in OPD. So you should not be starting MMF at 500 BD dose if the patient has not been on steroids. If the patient is being started upfront on MMF, you need to give the loading dose of MMF. Otherwise, if drugs like azathioprine or say other milder drugs, leflunomide has some role in the non-fibrotic HP. There is some data on cellular NSIP and cellular HP. There is some data with leflunomide. If these kind of drugs are to be started, obviously there has to be an overlay with steroids. Otherwise, MMF in the loading dose, you can do away with the steroids. All right. So taking it forward, Radha ma'am, how do you prognosticate these patients? We all know that the patient is a ticking time bomb and the outcome is going to be bad. So do we have any objective prognostic criteria? Can I talk about numbers that, 5-year survival is this, you have this chance? Is it, do we have some kind of a objective criteria? Ma'am, you need to unmute. Yeah.
Yes. We do have some scoring systems for prognosticating these patients. And it depends upon the age, gender, and ILD subtypes and pulmonary function tests, of course. And there are other objective criteria like if CRP is more, PaO to FiO2 ratio is less than 250, and there are fresh diffuse ground glass changes seen on chest CT which has appeared. This high score would indicate that there is a 6-month mortality. Or even if there is an in-hospital stay of 30 days, it too has a very bad prognostic indicator, And idiopathic pulmonary fibrosis, if patient needs a invasive mechanical ventilation, or patient who is hospitalized is being treated well and recovering, but ambulation is not done earlier, then also the prognosis in these patients start falling down very quickly. And I'm sure there would be more prediction models available. Kaushik has read it too thoroughly, so probably he knows more. But prognosis of ILD definitely depends upon whenever the FEV1 predicted falls down rapidly. Not only 5% as we have talked about PPF, but otherwise also it falls down and more. or DLCO falls down from the predicted values quite rapidly, or if fibrosis increases on HRCT rapidly, like you are doing follow-up at 6 months, and the fibrosis has increased, and then of course you would be repeating this CT. All this shows that the disease is worsening and has a bad prognosis in these patients.
So, of course, we have the gap index in IPF, which ma'am said that, gap is the gender, age, and the physiology of the patient.
Gender, age.
That's only for IPF, but for the non-IPF ILDs, it has been said that, for example, with hypersensitivity pneumonitis, which is the most common ILD in our country, to begin with, if you have a UIP pattern on CT, if the DLCO and FVC to begin with are really bad, if you've done a BAL and the BAL is non-cellular, it is a low lymphocyte BAL, then the outcome is going to be worse. So I think it is very, very important to prognosticate these patients, because, a lot of times these patients need to understand that this is a disease which is not like COPD or other respiratory illnesses. You are going to probably die of this disease. So I think preparing the family is very, very important. And the very next step.
Importantly, the patient who has recurrent exacerbations, irrespective of the underlying etiology, or irrespective of what you see radiologically, these patients getting hospitalized, having exacerbations, truly have a bad prognosis.
Absolutely, ma'am, absolutely. And I think the next logical step in this is in these patients is obviously the lung transplant. And Kaushik has already talked about this, but because everyone is asking about this, can I ask Mahendra sir to please, tell us again about the criteria of listing these patients very quickly. When would you list these patients for a lung transplant?
Yeah. As it's already been discussed, when you diagnose the patient as a UIP or a PPA, these are the patients we know that the prognosis is not going to be very good and that there is going to be a progressive disease. This is the earlier the better. These patients should be listed as early possible. And if there is a decline in the FVC of more than 10% in last 6 months, or there is a DLCO is less than 39% or 40%, these are the candidates who should be listed as early as possible. Apart from that, any person who is not responding to the antifibrotic treatment, progressive worsening in spite of the treatment, is again a criteria that you should be heading for a worse prognosis and should try. So these are the patients who are otherwise without transplant are not going to have a good survival rate. They should be listed as early as possible. If they do not have any other contraindications like age bar or no significant malignancy in the body, no severe cardiac issues, musculoskeletal BMIs within the range of 20 to 30, then these are the patients should be listed as early as possible, since the lung transplant program is becoming more and more approachable, available, and cost effective. Instead of spending money on recurrent admission, I think the lung transplant should be considered in such patient at an earlier age than what we used to do in the previous.
Absolutely. And I think as more centers take it up, as we become more confident with it, and a couple of years back, till 5-6 years back, we were also skeptical. But I think we have all now have some experience of our patients doing well with it. So as more numbers do take place, I think India would have a better outcome of these patients. So I had mentioned about nalbuphine. So a lot of people are talking about nalbuphine. Nalbuphine is not available as an oral presentation in India. It is only available in the IV form. However, that IV drug can be used as IM or can be used as subcutaneous. The injection's name is Nubane. Nubane is the brand which is available in India. So it is, because I am not an anesthetist, and our usage would be very, very limited to an acute phase where the patient has come with a cough fracture and the patient is really bad with the cough. So you would not give more than 10 milligrams subcutaneously in a day. And whenever you are supposed to give these kind of drugs, obviously you should involve the anesthetist with you. Nalbuphine is such a safe medicine that, post-operative, post-cesarean section pains and vomiting and all these things, it has been given. So the usual dose that I have seen in my practice that the anesthetist prescribe is for intractable cough. They would only give 10 milligrams subcutaneous, and it works very well for 24 hours, right? But you need to talk to these people before you prescribe these drugs. So, when you talk about acute exacerbations of ILD, this would be the Achilles tendon of ILD patients, and this is where most of these patients die. and very difficult to handle these patients. We are seeing a lot of questions coming on acute exacerbation of ILD. How do you start the management? Would you give antifibrotics? What dose of steroids do you give in these patients? So, Ameena, can I request you to please sum up the management of an acute exacerbation of ILD? What would you do in your practice?
Right, sir. So we've been following a very simple protocol for years now. Basically, a person in ILD exacerbation presenting to the emergency, first of all, rule out the non-infective causes, rule out pulmonary edema, rule out pulmonary embolism. Then most of these patients have been on long-term steroids or immunosuppressants. So infection, a very, very common cause. We very heavily rely on biofire, as much criticism as we may get for it. But the thing is that it saves us a lot of time. It saves us a lot of time, and one can always de-escalate once you get the culture if, the biofire over reports. So rely on the biofire, treat the infection accordingly. If it's an infective exacerbation, you could add steroids 1 to 2 milligram per kg per day of body weight. If there is no infection, no PE, no heart failure, no drug toxicity, you're purely looking at an inflammatory ILD flare. And in that case comes the role of pulse steroid. If there is an underlying CTD ILD, in that case comes the role of rituximab, cyclophosphamide, etc., IVIG and all. Then, of course, you start with oxygen therapy, you go on to HFNO, you go on to NIV, you go on to ventilation if the patient is not improving. But whenever you're ventilating an ILD patient, it is our responsibility to prognosticate the family that the outcomes of mechanical ventilation in a patient with ILD are very, very poor unless you're using it as a bridge to lung transplant. So by and large, just look at what the cause is, start empirical antibiotics, rule out infection. If there is infection, treat the infection appropriately. Lower dosages of steroids if you have an infection, higher dosages if it is purely inflammatory, and I guess that's about it.
Fantastic. Summed it up really well. And I think this is what we all do. And pulmonologist is supposed to be a poor man's doctor. If a pulmonologist uses a biofire, we are suddenly, under a lot of scrutiny. Biofire. Have you ever seen a cardiologist worrying about the patient's pocket? I'm not saying don't worry about the patient's pocket, but this is the right thing to do. There is absolutely no harm in doing it because, we don't suspect usually, for example, we recently had an ILD exacerbation wherein we could not really point out what it was. The biofire told us the very next day that we were dealing with PCP, though this is one of the causes of exacerbation. So had we only given this patient steroid, we would have lost the patient. We actually saved the patient by just giving something as simple as Septran. So there is absolutely no harm, Ameena, as you very rightly said, in doing a biofire upfront in these patients. This is one of those few indications where I absolutely support its use because the treatment is either this or that. Because if it is an infection, giving them 1 gram of steroid is going to be counterproductive. So whenever you have an acute exacerbation of ILD, please rule out other differentials. We had one patient recently who was referred to us with an acute exacerbation of ILD. They did have ILD, but they came to us with pulmonary embolism. So there was absolutely no reason or no use of the 1 gram methylprednisolone that the patient was receiving for the last 3 days in the previous institute. So I think very, very comprehensive management. You need to keep your eyes and ears open whenever you are dealing with an acute exacerbation of so-called acute exacerbation of ILD. The treatment is not just blindly loading them up with steroids. Please look up the differentials. And a lot of times you're actually not dealing with acute exacerbations, but with a red herring. So please keep that in mind. Very nicely said, Ameena. So Shrija, hypercapnia is something that everyone talks about with COPD and asthma and bronchiectasis, but we very often see hypercapnia complicating acute presentations of interstitial lung disease, and it is considered to be a really bad sign. It is, once you have hypercapnia in ILD, it is supposed to be a terminal event. So how do you manage the concomitant hypercapnia in these patients? Because they are hypoxic and they have hypercapnia. Now, if you give them a lot of oxygen, this is going to worsen the hypercapnia. If you put them on the ventilator, Ameena has already told us that, a lot of times we lose these patients on the ventilator. So how do you handle the hypercapnia in these patients? You think HFNC would make any difference? Or how do you justify the usage of NIV in these patients?
Yeah, thanks, Dr. Arjun. I think both you and Amina have already covered bits and bobs of this in the question before. But yeah, so before we act, like you said, once a patient has developed chronic hypercarbia, that means it is an end-stage disease usually. But then we have to rule out any recent exacerbation that the patient has gone through. And again, it comes back to the, like you said, a very intensive evaluation of the patient. So we have to again rule out comorbidities. Does the patient have combined pulmonary emphysema and fibrosis? Does the patient have recent onset pulmonary embolism? Has the pulmonary hypertension worsened? Does he have an OSA that's added on? Or is the patient in CHF? So again, I think we have to look into all these things and send the relevant investigations and work up the patient, because it does have a prognosticating, and I mean, patient may get better if the patient is in CHF, if you take care of the pulmonary embolism, if the infective exacerbation is taken care of. But yes, having said all that, if the patient is in chronic respiratory failure, you give them, it's very difficult to put these patients on NIV. I recently had a patient of IPF and they have rapid shallow breathing at, very high rate. They just cannot tolerate the NIV. And you start off with even a CPAP or very low pressures at 4-8. I mean, EPAP of 4, IPAP of 8. Even that's very difficult for them. One thing I think we tried is obviously HFNC would be something that you can start off with. So high flow nasal cannula gives an amount of, humidified warm oxygen that the patient can tolerate. It's through the nasal cannula. Plus, it has an amount of PEEP that will help, deal with the hypercarbia, and it reduces the dead space to an extent too. So definitely, I would say start off with HFNC. Add on benzodiazepines, add on a bit of opioids to reduce the anxiety associated with the anxiety part, and to reduce the dyspnea. So all these things, and other things like cognitive behavior therapy, there was a study shown that you can add on pulmonary rehabilitation when a patient is on NIV too. So that reduces the level of dyspnea and improves the compliance in such patients too. So before NIV, definitely try HFNC. That also doesn't work. Then you go on to a very low, pressures of NIV, add on benzodiazepine, opioids, extra psychological support, involve the cardiopulmonary physiotherapists, add on some pulmonary rehabilitation. And of course, like Amina said, we have to prognosticate such patients, make their family understand that it's no point putting them on the ventilator. And, a little amount of, I think, counseling and talking to the patient is required here. So I think it's just a blend of everything a bit.
Absolutely. And then, whenever you are ventilating a patient with COPD, NIV, COPD lung is a flabby lung. It is, even though it looks scary on a CT, there are bullae there, the lung is flabby. The lung is not going to rupture when you give them NIV. On the other hand, the ILD lung is a really stiff lung. And when you try giving high pressures on NIV, these patients are going to develop pneumothoraces and pneumomediastinums, and this is going to lead to a lot of trouble. Another very important point, Shrija, that you raised here was when you take care of the anxiety, when you actually give them a low dose of, say, benzodiazepine in a controlled situation, in a controlled manner, it would actually alleviate the hypercapnia and the respiratory distress. So it is not that we are saying that you need to give benzodiazepines to all patients who have hypercapnia or patients who are really ill and who are in distress. No, but you need to titrate your therapy, and sometimes taking care of the anxiety in these patients, the really bad respiratory rates, it does help. It can be counterproductive, but it does help in a few of these patients, right? Thank you so much for that. So, Kaushik, most of the drugs that we have right now, whether it is antifibrotics or whatever we have now, we all kind of use them in our practice, but the outcomes we all know are terrible. Whatever said and done, to my mind, I know it's a very, very controversial statement that I'm going to say next, but I believe in my heart that it is true that drugs like pirfenidone and nintedanib are more about statistical jugglery rather than anything else. I have not seen a patient in my practice being happy with these medications. So is there anything which is coming up, which is tangible, which shows good results, which can probably be a game changer in the next 5 years, 10 years? What are the new drugs in the pipeline? And do we have any drugs which are going to actually make any difference? I don't, want drugs, which do nothing. Is there anything which tells us that might be useful? Unmute.
So yeah, Arjun, I think I opened the match and then I'm facing the last ball also. So yeah. So like you said, I think we have a lot of drugs which we currently use, but then there is nothing to stop the progression of the disease because most of them just look at slowing down the process. So, but when I went through data about what's coming up, I don't think there are a lot of drugs which are on phase 1, phase 2, and phase 3 trials, but then a lot of drugs are also prematurely withdrawn from the trials because they don't meet the endpoints or they have critical adverse events. So there are a couple of drugs which I would say for IPF, where what we are looking at is nerandomilast, which is in phase 3 fibronir IPF study, which is a PDE4B inhibitor, which is actually trying to stop the progression of the fibrosis. That is one thing which is promising, and it is in phase 3. And the second one, which is actually a little more promising, which increased the FVC and also 6-minute walk distance, is an inhaled treprostinil for the IPF group. And this interesting trial which is going on is combination of pirfenidone and nintedanib, which is also an interesting trial which actually has a synergistic effect, and then they're looking at whether these drugs could be quite beneficial when you give both together, but then there is a lot of side effect concerns and adverse event concerns in that particular group. Other than that, if you take the non-IPF group, I don't think there is much newer things there, but then they are trying different regimens of cyclophosphamide, rituximab, corticosteroids, plus or minus, and that is what is going on there. But RA-ILD as such has tofacitinib trial which is going on, which is also have a promising results. I think everything is moving towards personalized medicine when it is going to be treatment for ILD in the next 5 years. I think a lot of gene work is going on, a lot of stem cell work is going on, and I think it's going to be personalized medicine for the future of ILD. I think that would be my take from.
Absolutely. And I think that is the way forward. Every disease, we now talk about personalized therapy. Everyone is now talking about, gene mutations in ILD. And we know that the gene mutations that are present in the telomerase shortening that is prevalent in the Indian subcontinent, we somehow follow the Western pattern of the gene mutations. And unfortunately, these kind of mutations are less amenable to pharmacotherapy. So hopefully we'll have something better. And just a point to ponder, out of all my panelists, how many of us ask for palliative medicine consults in our patients? Do we have palliative medicine departments in our hospitals? Do we ever ask about it? How many of us use morphine in these patients? I think we hardly ever do it. So my take always in managing patients with advanced ILD is, I might sound like a very primitive person here, but I think morphine is cheaper than a lot of newfangled drugs, and I see absolutely no sense in starting someone who's dying of their disease on drugs like nintedanib. You kill them with diarrhea. So it's always better to talk about rehab, drugs like opioids, taking care of their cough, giving them support. Very interesting data from US. I was reading this up the other day. Just talking to the priest in terminal ILD has been shown to decrease the cough and dyspnea as compared to all the pharmacotherapy that we have. So I think these are the simple little points that we often forget, but we should not, because this is a disease which unfortunately is terrible. So I think we've crossed more than 100 questions here. And I have last 4 minutes left, and unfortunately most of the questions are MDD questions where a clinical scenario has been given to us and they want us to interpret. I can't do that because there are no CT scans here and this is not an MDD. I'm so sorry, but if I start reading that history, it would take me 15 minutes to complete that history. I'm so sorry. You've actually put in so much effort, but I would not be able to take those questions. So 1 or 2 questions which we have missed out, which need to be discussed, I'll take them. I'll ask Radha ma'am. Ma'am, what is your say on doing interventional pulmonology in ILD? How often in your practice do you do TBLBs, cryo-TBLBs or surgical lung biopsies?
We don't. We would do TBLB if needed, only if it is an unclassified case, but these are बिल्कुल इक्का दुक्का बोलते हैं वैसा, because with the recent advances that we have, most of the time more than 90% of our cases can be very well classified and diagnosed well. So we don't do that. And
Thank you so much, ma'am, for saying that so nicely. We don't, I don't, and that is what I wanted
and
to
I
hear.
have,
Thank you.
as of now, I have not referred any patient. Yeah, even if I have a very good supporting surgical department who have VATS and all, but I have not referred any patient for TBLB.
Sure. So we would do a EBUS in a patient with mediastinal lymphadenopathy and an endobronchial biopsy in someone who has suspected
sarcoidosis.
We would do that. We would do that. If someone has suspected HP, there is absolutely no harm in doing a BAL in these patients. But if someone has clinically proven scleroderma, if all their factors are positive for scleroderma, there is absolutely no point in doing a surgical. We had a patient recently who had scleroderma, clinically apparent scleroderma, and a cryo-TBLB was done for that poor lady. She developed a pneumothorax after the cryo-TBLB and died because of the cryo-TBLB. There was absolutely no point in doing that. So this question has been asked thrice. Would you do a lung biopsy in someone who has a connective tissue disease related ILD? No, I would not. I already have a diagnosis. Why would I do that?
Arjun, I would say that a patient who already comes with advanced ILD and PPF, I don't see there any point of looking into what has been the etiology and just looking at, not other investigations, but just doing a biopsy in these patients. I would advise it all.
Absolutely, ma'am. And I think we have run out of time. It is already 10:30. Everyone is tired and everyone wants to go home and sleep and go back to work tomorrow. So I thank my panelists for being so patient and for answering all my questions so well. And it's always a pleasure, interacting with the pulmonary fraternity in India. We are going places, very, very proud of the work that Indian pulmonary medicine is doing, and the world is looking up to us. And a big thanks to the ICS for being, at the helm of affairs. Samaria sir, Nene ma'am, and Rajadhar sir for always being there for all of us. The enthusiasm that Amita ma'am brings into everything is so infectious, and I'm really looking forward to the conference webinar call. And everything you do, ma'am, you're a rock star. Thank you so much.
Great login also, Arjun. More than 1,800 logins.
Great. So I think ILD is something that is, work under process. Still bad, but I think as pulmonologists, we can make a lot of difference in the lives of these patients, right? So with that, as the final comment, I thank all my panelists for being here with me today. Fantastic discussion, and thank you so much. Have a great evening.
Thank you so much, Dr. Arjun, for that wonderful moderation.
Thank you.
Thank you, Arjun. I think you have to go take some water now.
Yeah.